So it seems that the ovarian carcinoma is now entering into a completely new arena. Something like, to my mind, like finding new hormones for breast cancer or something like immunotherapy, completely new thought process. Very interesting time for ovarian carcinoma. So, but the question which I had thought of, most of them stands largely answered. The whole day has been largely, yeah. Let's see. Yeah. There we go. So the topic I thought was that in my mind, ovarian carcinoma is addicted to BRCA, but is it just BRCA or HRD as we have been discussing? So I'll quickly go through 2, 3, 4 slides, and I intend to finish it in 7, 10 minutes because most of them has already been discussed n number of time, and it is actually a lot of access. But at the end of the day, if there are 5 or 6 questions and we have a takeaway message for 5 or 6 questions, I think that should be fine. Correct? Okay. So there was one data set. So I've divided according to the presentation. One was what is the incidence or the prevalence, rather more incidence, but the prevalence of the mutation. So first set of data set was the germline mutation data set. These studies were rather large studies, if you can see the numbers, so it is quite valuable. The point of interest, and if somebody wants to talk about it at some point of time, is that it is not just about BRCA1 and BRCA2, it's about a lot of other genes. So do you agree that is this the way we are going to go ahead forward, that are we going to order BRCA1 and 2, or we are going to order this approximately 20 set of genes, which is also called as HBO genes, hereditary breast ovarian cancer genes? Chanchal, what do you think? Are you going to order 1 or 2, or are you going to order all of them?
Well, at this point of time, we are not doing anything in this regard with ovarian cancer, but the way it's looking at, probably at some point of time we will have to look into it. And if we are doing only, I think the best thing would be to go for NGS and look at all these sets of genes rather than looking at BRCA1. But at this point of time, we should start doing the BRCA at least.
So have you started doing it, or have you made up your mind by now that, okay, you're going to...
Yeah, I think we are making up our mind at this point of time. And I was just talking to Jaya, I think even in Tata Hospital, they are not doing routinely for ovarian cancers except for selected patients who are referred for it. So I think it's time that we need to think in those lines and start doing it. We have not started doing it.
You have a point to make.
Sir, if I may interrupt, I come from UK, where we very routinely did BRCA testing on all ovarian cancer patients. And I've moved to India about 3 months ago, and I found out how much it costs to do a BRCA1 and 2 test, and I've been told it's only been selectively done and costs around 50,000 rupees.
20,000, 20,000, 15,000. 10,000 is going like that?
Yeah, I'm hoping it will go down like that so we
Okay.
can start
So
doing
it's a
the test
cost
more
of a PET
often.
CT. It's a cost of a good PET CT scan. Okay? I mean,
So-
I don't say that you should do it.
More usage.
Yeah.
Yeah, of course. And then we need to have a
So now the
model.
cost is cheaper. Would you be willing to do many more of these BRCAs and HBO gene tests relatively universally in your ovarian carcinoma patients when
I
they're
certainly
appropriate?
would, sir.
Okay. Okay. So it's changing.
Taking into account our Indian scenario, we should be able to give them the service once you do the test. And testing the relatives also, we should have counsel them and
Extremely
probably-
important. I'll come to that point because there was an abstract about telephone counseling. So I am not going to talk about telephone counseling, but the counseling, which is extremely
Once you
important.
get the reports, then what we are going to do with that, then that is again an issue.
Yeah. So, Dr. Tiwari, I think I had access to what you said in the morning that almost universally you're doing.
Yeah, we're testing for BRCA1 and 2, but we don't routinely test for all those other
Okay.
markers.
Would the presence of this HRD report now alter your thought process that would you be doing more, or it will be waiting an FDA approval for an indication for olaparib or from
Yeah,
that?
I think moving forward, what we're hoping to do is that every woman with ovarian cancer gets an HRD test.
Okay. Okay.
And that's what I think will happen.
And you do HRD tests from Myriad.
No, we do BRCA tests from Myriad, but you know, the Clovis has an HRD test, Tesaro has an HRD test.
Okay.
There's different HRD tests that are being developed with every drug. The FDA has a incentive that any new drug coming to market has to come with a companion diagnostic.
Okay, Jay, are you doing? Are you starting to do the BRCA as the panel is saying, or are you inclined to, or you are planning for, as you do a lot of gynec oncology?
Presently, what we are doing is all the young patients and those patients with a family history, those or a history of breast cancer. Those are the ones we are referring for germline BRCA testing
In the ovary.
Of the ovary. But of course, I know the recommendation is to do it in all high-grade serous, but presently, because of whatever cost and logistics, restricting it to doing it.
So you're doing it from the patients who have got relatively stronger family history, because you expect more likely for them to be BRCA positive.
And those who are younger, less than say 40 years
But
of
the
age.
data does not say that. There are a lot of patients who don't even have an iota of family history, and a lot of them turn out to be BRCA positive.
Yes, but presently looking at the data, I think we should be doing it for more patients who are for most of these high-grade serous ovarian cancers.
So most of the people, I would say, are now coming to the point that this is almost becoming a standard of care. And fortunately, the cost in our population is relatively cheap, so it is not that difficult. So
Would you recommend that for the tumor or the somatic mutations or the germline?
So I'll come to a small point on that. That is another question, because whether you're going to do germline or whether you're going to do somatic. So one question answered is that most of the people are now inclined to do this test, particularly if olaparib or any other drug becomes available, because it would have a therapeutic implication. Fortunately, we're getting it free of cost at this point of time, and doing it only for counseling is not an easy task in our country. Would we agree with that? If it is a therapeutic potential connected to it, then it is relatively easier to counsel the patient because they tend to agree with it.
Sure. I just want to ask, what is your experience with the Hrd deficiency testing? Because I haven't been able to do any of that.
So India does not have Hrd deficiency testing available.
Have you, because you mentioned some of them.
It costs about 3 lakh rupees. It costs about 300,000 rupees, so it's very difficult to get an Hrd
In
testing.
fact, the definition also of platinum sensitivity and resistance will change, which BRCA positivity I know. So the definition, what we used to say, platinum sensitive, platinum resistant, may not be very, it will not be a definition once we start doing BRCA testing. It will be BRCA positive.
So far,
BRCA
all the PARP inhibitors have been utilized in patients who have responded well, mostly platinum at this point of time.
Platinum sensitive, I am
and the
aware of
previous chemotherapy was considered as platinum sensitive. So there is actually some data suggesting that the response to platinum resistant population may not be zero, but may be suboptimal. Would you agree with it, Dr. Tiwari sir? The response to olaparib in non-platinum sensitive.
Yeah, it's interesting. With olaparib, it's unclear, but certainly with the NOVA study with niraparib, even in the non-germline BRCA patients that were HRD positive, if they received niraparib, they did better than the people that were HRD negative. So it's not clear. I think the HRD assays in the United States, we don't have any HRD assays that are commercially available either. The only way we get them is if we enroll patients on one of these trials. But soon enough, I'm sure that niraparib is just about to probably going to be approved within the next month or so, and with it'll be approved alongside its HRD assay, and that'll make it available.
But does that indicate that niraparib is probably a more potent drug than olaparib?
That's what was shown by Dr. Tiwari in the morning, and I think Shuna Naug also showed that slide set that which shows that possibly niraparib is perhaps the most effective drug. So that is perhaps one of the things which was shown. So this was the question about somatic mutation, and I think wide variability has been documented of 4%, 5%, 20%, or 30%. In this data set, there was the one which was shown today. The total incidence was approximately 4%. So if you were to do a somatic mutation also, your increment will be approximately 4%. The somatic mutation testing the turnaround time in variable lab is approximately 3 months on tissue. The costing is approximately not less than 50 to 60,000. So I want to know from all the people who sent tissues for NGS, if they're sending it for one reason or the other, are they okay with what I'm saying, that this is usually the turnaround time for NGS for BRCA1 and BRCA2, and this is the costing, and will it offset your thought process with the volume of 4%?
Oh, I think so. PARP inhibitors work irrespective
That's
of germline or this somatic mutation.
so. Would
if
you
it-
search for somatic if germline is negative?
I don't know that. I don't have the answer.
4%.
Yeah, but they're independent of each other.
So once if they work, I think so they work.
So in
So,
an
see,
ideal
one
world-
question is what you're committing is the final thing that this trial actually suggests that you don't have to have a BRCA mutation, you don't have to have an HRD, you can get away with the niraparib drug without anything because all class of patient benefit from this drug. So actually that raises the question, why should you test the patient, because it seems all are benefiting.
If you look at the data and if you look at the costs of treatment, I think if it's germline negative, it's more prudent to do an HRD.
Yeah, it makes sense because if you are HRD, you will have patients who are not BRCA positive, but they have possibly other reasons to be HRD. So if you were to look for somatic mutation alone, then you'll have to search for HRD to do it. And one could raise a bogey of the fact that even if you're HRD negative, still you would respond, although volume of response will be relatively smaller. So one of the benefits that we could have when we are doing all this testing is that if you have a HRD negative, germline BRCA negative, which is automatically synonymous, then the benefit is approximately 4 months. So we may or may not be able to offer the thing. So this was about the telephone delivery, and my point about is how comfortable are we counseling the patient. So who are the people who are actually involved in counseling, who actually do BRCA test among all of us, largely medical oncologists, some surgeons also I'm sure, and who face the counseling issue and how comfortable they are. Can we start with somebody? Somebody who does it, you do the counseling, you're comfortable about counseling, the problem that you face during counseling, because I faced a lot of problem during counseling.
Yeah, we do it very sparingly only, and I really don't have any much experience about counseling.
And do you think it's an area of need because counseling is really required?
It is.
Okay. Anybody else has an opinion about it? Dr. Tiwari, I'm sure he would have a lot of experience. Probably
Yeah.
he will have a genetic counselor to talk about.
We have a genetic counselor. I mean, the counseling is very intensive, and what gets complicated is when you get results back and you have these variants that may not have much clinical relevance, and there's all these nuances associated with that. So we send them to a genetic counselor, and they do a great job. But I don't do any counseling.
Anybody else who does get involved in genetic counseling and has an experience, feels about it? Because there is a downside to it. You have got an ovarian carcinoma. You have got an ovarian carcinoma, proven positive, given olaparib, the daughter comes positive, and then a whole new story starts and a big problem. So
my question is,
okay.
Let's suppose that daughter has the BRCA1 positive.
Yeah.
What are the insurance implications of that?
I don't know, but I normally tell them.
Because she'll be labeled as.
I don't know. I normally tell them that try not to tell the information till this thing is sorted. It's a completely new thing. I think we can have an answer from US. How does insurance handles this BRCA positivity? I assume we should be able to mature to that level eventually.
Yeah, there have been no
Very relevant
cases.
question.
There have been no documented cases of genetic discrimination based on BRCA positivity in the U.S. Meaning, no one who's got a known deleterious mutation has been denied, like a life insurance policy or health coverage or things like that. At least nothing's been reported thus far. But what we typically do is if your patient has a BRCA mutation, you find out what that mutation is, and then you look for the specific mutation in the offspring or the sister or whatever. So you're not ordering the whole panel on those on the relatives. You're looking for an isolated mutation, which doesn't create such a red flag as it might if you order a BRCA test on all these relatives. But like I said, there have been no reported cases of genetic discrimination if someone's BRCA positive.
At least in the US.
Sorry, in UK there were no insurance implications whatsoever. They were not even required to mention in the insurance form that they are BRCA positive. Because being positive doesn't mean you have the disease. No. Being BRCA positive doesn't mean you have a condition.
But this situation is not yet clear in the insurance sector of India so far.
Yeah,
So
I mean,
it
in UK
will evolve.
definitely.
It will evolve.
In my feeling, I think it should not be an issue with Indian insurances because, say, for instance, having a family history of cancer doesn't deny you to get a medical insurance. So I think that answers logically that having been tested BRCA I don't think an insurance company has, right now the law of the country cannot deny you an insurance.
Possible.
That's what my logic goes.
Viraj, it's like if your dad is a diabetic, you're likely to be a diabetic by more than an average person. But that doesn't mean your insurance policy will be different.
So the problem would happen is if there was a genetic test which would tell that you are 100% guaranteed to get a diabetes, then there will be a problem. You know, so if somebody has a family history, it may be easy, but if somebody has a gene, it gives 85% probability of a lifetime risk of, let's say, breast, depending on how the things are.
I think it wouldn't be a problem, only your premium price will get higher.
So it's an issue at this point of time, not clear. Jaya.
What I feel is
You're
a
lucky.
major, because they all go to Dr. Serene and the lab, but what I feel is a major issue is more of a social issue, because once they have, then they have offsprings, and you know, some of them, like there are young women who are either not married or have not completed their family, so the implications for the whole of them and then the whole family, even though you're not directly involved in the counseling, but you're the treating, there are a lot of social implications which occur where I think that is a major problem that we face.
So now that these genes are going to get tested, I think people should be prepared on counseling front completely, because it can be a complete disaster. It can be very difficult to handle once you have the report. And one of the biggest problem that happens is when you have a VOS, a variant of unknown significance, and you really don't know how to handle it. It becomes very, very difficult. So a time spent in a pre-test counseling or a post-test counseling is a very, very important thing. Now that we are going to enter this terrain, it is extremely important that we are tuned to it.
And you have genetic counselors here, right?
Jaya has.
Yeah. So let them do it.
All our patients will go to her.
I think they have a genetic lab which is, Dr. Serene has a...
It's the Mecca of, this place is Mecca of genetic things. So they can afford to. But hey, we all are genetic counselors.
I'm not.
No, in India we are all genetic counselors. Okay. We are all palliative care experts, we are genetic counselors. We are everything.
Certain companies have genetic counselors and we can hire their facilities. Normally they can come at a consulting clinics or hospitals.
True, very true. They do come for the first or the second visit, and after the 10th visit they stop coming. I've done a lot, so I know that. Okay. So this was, now what are we going to do? So this was the abstract which Shunanak showed about. This was the second or the third second update on Dr. Lederman's data on olaparib. They had shown in a phase 2 trial that progression-free survival is benefited. I think the hazard ratio was a 0.4, 0.5. But this was an unplanned or a secondary analysis of overall survival. And suffice it to say, you can break into one group or the other group. The overall survival was not evident. So this was one thing. Second was from the Solo 3. And the third was the actually most interesting article, I would say. I think it means the next level of treatment, like from moving on from tamoxifen to something else, which is this, because this showed remarkably expected germline benefit. Even if you don't have a germline benefit, have an HRD, and actually there was a benefit to the patient who had no obviously known mutation or HRD. It seems everybody seems to be benefiting on this drug. So this was, to my mind, the path-breaking article. Olaparib was restricted approval to a drug, smaller number. This is opening a new option. It's like a carboplatinum for ovarian carcinoma. You have to give it to everybody. Do you agree with that, Dr. Abha, sir? It opens up a new option. It's a new carboplatinum or tamoxifen of an ovarian carcinoma.
Well, looks very, very promising, but I do not know in practice whether we can use right now.
Yeah.
As the Americans say, it may not be the prime time.
Are you saying that?
Well, the Clovis that makes rucaparib and Tesaro that makes niraparib, they've submitted their data almost simultaneously. The Clovis data had been presented at ASCO a year before this was presented at ESMO. And, a week and a half ago, the Clovis drug was approved, and I think that niraparib is going to get approved. It's a real groundbreaking trial. It's the first phase 3 randomized trial of a PARP inhibitor. As you showed, it was positive in many different pre-set endpoints. And, it's starting a new trend. The paper was presented, and it was immediately published in the New England Journal of Medicine. Same week.
Simultaneously.
Yeah, and it's got its companion diagnostic that's being under review. It's exciting stuff.
So that brings a small point that one of the article actually mentioned that although the numbers were small, but non-white race confidence interval actually crossed 1. So would it matter, or would you say it's just a small number? It's because we are non-white race, so I raised up this issue. There was one of the article elaborate that non-white race people like us don't tend to benefit as many as Caucasian race would.
Yeah, we have to study it in Indians also.
Okay. So another question which pops up to mind is that the data of olaparib, although there are much more data on olaparib, the PFS data, not about the hazard ratio, the quantum of benefit is relatively small, whereas the benefit seen in niraparib is approximately 22 months. So would we mean that the moment we have two drugs, olaparib will be out of contention and niraparib will be the drug because it can be given to more people and there is no cross-trial comparison, but from trial to trial it sounds like it is possibly going to be the winner.
Yeah. The other thing is olaparib, you've seen the better results only in the BRCA positive germline mutation, whereas niraparib is across the board, which is another important point, which will come into play.
Right, and the olaparib approval is kind of interesting because it's approved for fourth line and beyond. When rucaparib got approved a few weeks ago, it was approved for third line and beyond. This may get approved for second line.
Oh, wonderful. So that raises a small question about there are few platinum refractory patients who do respond to non-platinum drug, single or a combo drug. Are we going to offer them, this is in context of what Dr. Thopas was mentioning about, are we going to offer them olaparib, niraparib whenever we get a chance to? So what will be your thought process? Would we value the platinum sensitivity and PARP inhibitor, or we would say that is not the point, if the BRCA mutation is there?
Well, ultimately, everyone becomes platinum resistant because the vast majority of patients treated are not cured with primary therapy, and if they've had a good operation to begin with, they're platinum sensitive, but ultimately they become platinum resistant. So essentially, any BRCA positive patient is going to be eligible for PARP inhibitor. The interesting thing, again, though, olaparib is only approved for germline BRCA mutations in the States. It's approved as a maintenance drug in Europe for germline or somatic. Rucaparib got approved in the States, germline or somatic. So and like I said earlier, with the HRD testing, probably 50% of patients are going to be eligible. And I think our definitions of platinum sensitivity, platinum resistance are going to possibly disappear because the way the trials are now being done is you have to be platinum resistant after having been initially platinum sensitive, meaning that you had to have progressed within 6 months of the last platinum regimen. And so I think we're not going to be talking about platinum sensitivity as much as anymore.
That's what you will do.
Rucaparib has got a FDA approval irrespective of platinum sensitivity or resistance, right, sir?
It's been approved for third line.
Third line. And you
and
don't have to
beyond.
document a sensitivity.
Germline or somatic.
Mutation, yes, but irrespective of sensitivity or resistance.
Right. They don't.
Rucaparib has got an approval for that.
Yeah, rucaparib does, and olaparib was also approved for fourth line and beyond. They don't talk about platinum sensitivity in the label.
That's why.
Yeah.
So there's a small clinical scenario. If you have a patient who was planned for bevacizumab with chemotherapy, and as you suggested in the morning that you would like to continue bevacizumab as maintenance, and you come to know the patient is BRCA positive, what are you going to do? Stop bevacizumab, move on to the next drug, keep olaparib for the next line, combine the two.
I'd save it until they progress.
So continue Avastin.
Yeah, I've seen. So if you look at all the bevacizumab studies, the curves come together when you stop the maintenance therapy. So I've had some very good results continuing bevacizumab, but I'm in a place where I can get it and use it like that. But I'd keep it. I think though, but the key is that the patients that are HRD positive are going to, once we get the immunotherapies and understand how to use them better, the patients that are HRD positive are going to be viewed as having very high mutational loads and being seen as foreign tissues. And so the immunotherapies are going to be very effective. I really believe in this. I think we will be able to cure this disease. But it's going to be a combination of all the stuff we do. Aggressive cytoreduction, platinum-based chemotherapy, anti-angiogenesis therapy, PARP inhibition, checkpoint inhibition. The pieces are all there. For 15 years, we had nothing.
Yep.
Same old drugs.
Exciting.
It's very exciting.
Very exciting. Very exciting. Thank you. Thank you. Thanks a lot.